is our next speaker. She's a professor of internal medicine in the section of infectious diseases at the University of Nebraska Medical Center in the States. She's a clinician and an active researcher. Dr. Swindells has many years of experience in translational and clinical research in the field of HIV, and with a special interest in tuberculosis co-infection and long-acting formulations for antiretroviral agents. So welcome.
Thank you, Karen. And thank you for this opportunity to talk to you about potential opportunities, but also several challenges for looking at long-acting treatment for TB, both as prevention and potentially for active disease as well. So just briefly, the long-acting injectable drug development, this is mostly based on drugs available in the US and Europe, but several are available in other countries too. So this is a little bit slipped to the left, but you get the general idea. So long-acting injectables developed about 65 years ago, followed by penicillin, some contraceptives, naltrexone, 1984, Depo-Provera, medroxyprogesterone acetate in 2004. Rilpivirine actually first developed in 2009, along with paliperidone. Cabotegravir 2012, and as everyone knows, these two together have produced some exciting results in the area of HIV treatment by monthly injections, and there'll actually be a little update on that at the conference next week with a combined analysis of the switch study and the naive study, and testosterone. So why should we want to give people long-acting injections when we have tablets that work perfectly well? Well, the main reason is you don't have to take them as often. You know, a monthly injection for some people is very much preferable to taking tablets every day. Bioavailability is improved. There's potential for less adverse events, although this isn't necessarily evidence-based at this point. Similarly for drug-drug interactions, that's also a potential advantage which we have yet to really establish conclusively. And there's a theoretical improvement in treatment adherence, which is of course critical for both HIV and TB, and for programs using directly observed therapy, potentially a lot of cost saving and decreased resource use from monthly injection as opposed to daily oral therapy. And some evidence from animal studies that long-acting injections penetrate tissues better, possibly at the site of action of the disease. So what are the characteristics of long-acting agents that are currently used successfully? So on this table you can see there's Depo-Provera, there's risperidone, there's cabotegravir and rilpivirine. And if you look at the daily oral dose, you can see that they're all small. Half-lives are relatively long, and I'm talking to a room full of people who, many of you treat patients with tuberculosis, and you can see quickly looking at these daily doses in TB, we are a long way from that in terms of potency. So here we are with the TB drugs in terms of the daily oral doses, some of them very large, half-life and therapeutic concentration. So right away we have a challenge with the drugs that we have to work with, but it's not hopeless by any means. So the basis for a successful long-acting agent is high potency combined with low clearance. So here's a drug that has high potency, and here's a drug that has low clearance, which remains above the target concentration for a long period of time. Again, with a high potency drug and low clearance, you see that the plasma concentrations can remain above the target that you want for a period of time. So this is what we're aiming for, a potent drug with low clearance from the body. So the other characteristics that influence What works well are this combination of water solubility, the half-life, and the target concentration. And the gray sort of scribbles in the middle are the characteristics of the currently used successful long-acting agents. So these are all compatible. This is a surrogate for clearance, and this is derived from the C-min value. So these are the range of the existing LA agents, and this is where first-line TB drugs fit in. And as you can see, none of them really fit. Isoniazid is much too water-soluble, disappears very quickly, and the rest, none of them fit into the triangles in the middle. But the newer drugs, newer TB drugs actually look better, and some of them really look quite promising. So the 4 that are on the right of the screen. And the first pass at looking at these, we have examined them in physiochemical and pharmacokinetic characteristics using PBPK modeling. So this is a modeling study, which is, of course, very different from a real study in animals or in people. But we can see a little glimpse here, perhaps, that the newer TB drugs may have some potential for long-acting formulation going forwards. Isoniazid, not so much. And so Janssen, who are the developers, as you know, of bedaquiline, have actually made an aqueous microsuspension of bedaquiline to look at whether this is useful for long-acting injectable. So this is their data from a mouse model. And so looking at this, a gram of the injection of their long-acting formulation may maintain plasma bedaquiline concentrations in the range that you want for a month. But a gram is a lot. And the current formulation that Janssen have made is 200 milligrams per mil. So we're talking about a 5 mil injection, which nobody wants. But in the mouse model developed by Jack Grosset and now by, with Eric Nuremberger, looking at a model of latent infection developed by an aerosol infection followed by after a vaccination of the mice to simulate the model of low-level latent infection. And this is the oral validation of the model, looking at the different doses of bedaquiline, and this is with the LAI, which stands for long-acting injectable version of bedaquiline that Janssen have made. And you can see from the various different doses used that a dose of bedaquiline at 160 milligrams per kilogram is as good as any of the others. And over 12 weeks, once monthly dosing with this dose demonstrated superior or equivalent concentrations to daily or oral administration of rifampin, or the same oral bedaquiline dosing. So it looks very promising for potentially for prevention, although of course we don't have human data on how well this works as prevention, and even for treatment. So in terms of moving forwards, we have published a paper on this topic with a target product profile for what we think long-acting injectable agents for TB prevention should look like. This is probably pretty much impossible to read, but the paper's in the Union Journal for those of you that are interested. So in summary, I think that on the heels of long-acting injectable antiretroviral therapy, which I think we would all agree is very exciting in both the treatment and prevention arenas, there is potential for TB, but the existing drugs are not ideal candidates, so we have quite a bit of work to do to develop suitable formulations. There are, as you know, new chemical entities coming along for TB, many of which may be a little bit more amenable, and these are something that we're going to be looking at. We don't currently have reliable PD models, but those are things that we're working on, and we have new initiatives ongoing to develop these drugs, at least through the preclinical development and then hopefully to first-in-man studies. And so I'd just like to acknowledge a team that helped me with this through an NIH-funded consortium. It's called LEAP, which stands for Long-Acting Extended Release Antiretroviral Program, but we have a TB group that are listed here, and to the other collaborators that have helped with this effort so far. So thank you.